is to share moments with all my friends, and particularly, as you know, my friend Jim, and this is one of my picture with Jim in Brazil, as you can see, and I'm very sad to think that I will never be able to do that again. I want also to thank you, Ricardo, to have invited me to do this lecture. You know how I am very, it's a very important topic and a very difficult topic for me. And thank you again for you and all my Brazilian colleagues to let me present it. So when we think to antenatal lesion, the first thing to think about is the role of the neurosurgeon in the prenatal team. And I think this is very important, and we must stay in the center of the team, and we must avoid to be only a spectator and only doing what we are asked to do. We must be an actor of the show. And as neurosurgeon, in fact, we are super expert. We have to deal with very specific problems, as you know, hydrocephalus, spinal and spinal cord, cyst, craniosynostosis, and so on. It's always a secondary clinic. And my first message is that you must find that in many cases, your colleague, including the obstetrician, including the perinatologist, have absolutely no idea of the pre and the postnatal disease. So for them, what is a child at 10 years with a myelomeningoce or so on is completely an ignorance for them. And when you have your first clinic with the parents, you must keep in mind that they know that there is something wrong, they are scared, and in most of the cases, you are the last hope, or in cases, the messenger of bad news. So for me, it's always an emergency. I try to give an appointment, to give a rendezvous as soon as I can, which means the day after or two days after the call of my colleague. And in many cases, it will be the first contact with the parents and the beginning of an history, which can continue for many years. I will have not enough time to give some ethical problem, but this is also for us one of the most ethical situation in our practice. Our practice depends on regulation and laws in our country. That means that my practice, the practice in Brazil, the practice in India, the practice in the States are completely different. In my country, we have mandatory ultrasound at 10 weeks, 5 months, and 8 months. We have access to MRI for any children if needed. We are recognized reference specialist. That means that I'm a recognized reference neurosurgeon for any antenatal cases. One thing which is very special in France is that abortion for medical reason is allowed until birth. That means that if we need to do an abortion, for example, for a myelomeningoce, it's allowed at the 24, the 28, the 32, or even the 39 or the 40th weeks. But all the decision must be taken in a weekly multidisciplinary meeting. And there are 44 centers in France which discuss every week all the difficult cases. Our practice depends also on philosophical, religious, and ethical consideration, and we'll see some during my presentation, which means that our practice depends on ubiquitous consideration. the same for all of us, but also on circumstantial or local consideration, which means that the things are completely different, for example, for me and for people who are living in Brazil, which means for most of you. And we must always keep in mind how to work, how to act in the best interest. But when we think to that, are we acting in the best interest of the fetus, of the parents, of the society, or to protect ourselves? And you know this triangle, there is always a discussion between what I must, what I want, and what I can. What I want is that, do I need to take care of my personal decision? Is the fetus a person? Is handicap acceptable? What are the moral rules given by my culture or my religion? Do I want to be appreciated? Do I want to be just equitable? Do I want to be a good doctor? And at the other hand, what I can, and I can very few things. What is possible to do in these circumstances is to terminate the pregnancy, but not everywhere, to welcome a child with a handicap, or to propose antenatal surgery. And we must keep in mind that the first proclaim whatever it is will stay forever in the memory of the parents. And you know that there are very, very terrible sentences we must absolutely avoid. You will be a vegetable, you will better terminate the pregnancy, you are young and you will make another one. Because at this moment, the traumatism is not done by peaceful words, but by negative sentences without an appeal. And the president of the French National Ethics Committee has said what is called the free and informed consent is before all the recognized and given right to be allowed to say no, and the consents come after. It is to say yes after the clear possibility to say no for the family, which means that as far as we can reach the consent, the informed consent from the family. To obtain a consent from the parents, but in front the father doesn't exist, that means that only the mother has to say a word and to give his consent, whatever we are doing to a fetus, and a consent not to what I think or what we think to be the best solution, termination or not termination, for example, for us, but the consent of making an ethical choice. And the parents must absolutely have the power to say no to what we are going to propose to them, and totally to say yes, whatever is proposed. That means that the information must be not too exhaustive because they are unable to understand, not catastrophic, not optimistic, not general, but pertinent, adapted to the future handicap, adapted to the possibility of understanding, of their understanding, and adapted to their sociocultural environment. And this information must be given by a specialist who is able to take care in child the whole disease of the future child, pre or postnatally. If we look to what we deal in our group, as you can see, the disease and the malformation of the central nervous system as from far the most frequent, which means that we have a very busy antenatal clinic. Me or my colleague Timothée are seeing 5 or 4 pregnant women or pregnant couple a week. And if we look to the modification during the last years, what happened is that we are more and more seeing neurotube defect. I have not the precise data, that's why they are not in my slides, but last year we have seen more than 100 neural tube defect in our clinics. And as you know, to be simple, in fact, there is two big groups of dysraphism, the open dysraphism and the occult dysraphism. And the group of occult dysraphism is a very, very heterogeneous group. And among them, I will only spend some time on limited dorsal myeloschisis on LDM. I will have no time to discuss all the other malformation. So first question, what we learned from the embryology? The first thing we learn is never trust the embryologist. In most of the cases, what we have in our books are coming from animal models, very often short and very often old series with a lot of artifacts. But evenly during the last year, we reached the genetic and molecular biology evidence. First of all, you know, with the embryo, the chick quail embryo. And after that, with the genetic, and what is important to understand is that specifically for what we are dealing with, which means the spinal cord, we have a total conservation of the sequences of the gene, and particularly the OX sequence during the times. And we have now, for the last 10 years, many animal models from the zebrafish to the monkeys, but most of them are confusing, and in a lot of cases, it's very, very difficult to understand what we see or what we discover. And day after day, we understand that it is much more complex that we know about the embryology on spontaneous model or on provoked model with some drugs like here in adriamycin. Most of you know this cartoon. The first time I show it, in fact, was in Iguazu for one of the first course in pediatric neurosurgery. Maybe some of you were here. And we all know or think to know that the things are relatively simple. It starts at the 15 days of pregnancy. And then during the 15 days after, we have the orientation of the embryo, the trilaminar delimitation, the appearance of the first summit, then the neural fold fusion, the appearance of the neural tube, and that's progressing from the middle part of the embryo, which is in fact the neck, and goes anteriorly to the anterior neuropore and posteriorly to the caudal neuropore. And this is done before the end of the first month. And after that, we will have the secondary neurulation, which is a different problem, but we will speak not too much about the secondary neurulation today. So we all have in mind this classical drawing, but we also have in mind that it can't be the truth, because as you know, it can't explain such dysraphism as this one. This one was published by Roberto some time ago. And in fact, probably it's much more complicated, and there is probably several dots of starting of the neurulation. As far as the time is going, the more and more complicated it is, which means that we can keep the model we know and understand, but realizing that this can't be the absolutely truth. So to be schematic and to start, when we think to spinal and spinal cord development, there is three major periods: the gastrulation, the neural tube closure, and the secondary neurulation. And as for the three musketeers, there is of course 4 times, the gastrulation itself, which is the initial period with the trilaminar embryo, the neural tube defect, in fact, with two periods, the primary neurulation, and after that, the disjunction of the neural tube from the ectoderm, and the secondary neurulation. And each time has its malformation. The gastrulation can conduct to split cord abnormalities and neuroenteric cysts, the primary neurulation to open neural dystrophin, which are the myelomeningoce, the disjunction to incomplete or premature malformation, which are dermal sinus, LDM in one side, or lipoma and dorsal lipoma in the others, and for the terminal spinal cord, for the secondary neurulation, complex lipoma, fatty phylum, myelocystocele, or caudal regression. But today, we will only focus on the neural tube abnormalities of the neural tube closure. And we will start by the abnormalities of the primary neurulation, which are the myelomeningoce. So if we think about myelomeningoce, all of us know that they are the true open dystrophism, they are folate dependent, and they involve the whole central nervous system, spinal cord, and brain. So just to summarize the embryology, what can we say? The dystrophic states are best understood from an embryological perspective. Each can be associated with neurological dysfunction through a variety of mechanisms. The KIM presented seems to provide a unifying classification of these disorders, but all of this is probably completely wrong. So now, if we look to antenatal myelomeningoce, we all know what are these myelomeningoce is the non-cord closure of the spinal cord and this attachment through the placode to the skin and along spinal cord. You have here two examples, postnatal, antenatal, and ultrasound, and the same fetus after its abortion. And just keep in mind that because we will discuss of that, the difference between the true myelomeningoce and the myeloschisis, because I will spend some time at the end of my talk on that. So the dream is to do the diagnosis of myelomeningoce as soon as possible. It's theoretically possible to do it. There is many papers on diagnosis on the first trimesters, but in fact, you need to spend a lot of time to do it. It's difficult. And even for a good ultrasonographist, if he isn't focused on specifically this kind of malformation, it's mainly difficult. You can just look for the intracranial translucency and the aspect of the neck, but in most of the cases, it's difficult. On the other hand, it's always, in most of the cases, it's easy on the second trimester. It's related to the CSF leak with the microcephalus, with the classical aspect of the front horn, the front head, the forehead, and or of the ventricle, and of course, with the typical aspect of the Chiari malformation. I will spare the banana and the citrus, but anyway, in most of the cases, the diagnosis was done looking from the head. In most of the cases, MR is useless. And if you go down after that, you will find out the myelomeningoce with long spinal cord going to the skin, no skin covering, all the roots going back to the canal. And if you have lateral slices, you can see all the roots going upward from the spinal cord to the spinal canal. Sometimes it's more difficult when you haven't a sac, but it's exactly the same aspect. You see the spinal cord, you see the placode, and you see the wide opening of the spine, the true spina bifida. And the only thing which is important to note is the level of the malformation, because this will indicate the postnatal deficit. In most of the cases, what we need to look is where is S1. Look to the sacral vertebra, and the fifth in most of the cases is invisible, so you count 1, 2, 3, 4, and you find out S1. Or you need to look the difference of angulation from the sacrum to the lumbar spine. Of course, you can have associated findings, the deformation of the foot, the intracerebral abnormalities. We have seen the ventricular dilatation, but you can have also, in some cases, this kind of nodular heterotopy, of intracerebral nodular heterotopy. And in many cases, and I will show you that in just one second, in many cases, most of the half cases in myelomeningocele, you will have an abnormality of the corpus callosum. And the role of the ERM, of the MR, is or to do when the presentation is not favorable for ultrasound, or the mother is obese, or to see the intracranial abnormalities are the interest of the MR. And of course, you can see exactly what you have seen on the ultrasound. This is a paper we have just published a few weeks ago in our team, in our series. If you can see what you can find out on myelomeningocele, as you know, there is 100% of Chiari. If you haven't a Chiari, it's not a myelomeningocele. You can have about 50% of microcephaly, 50% of ventriculomegaly. You have 60% of abnormality of corpus callosum. That's why for us it's not a contraindication to do antenatal surgery. These are the nodular heterotopy, very few abnormality of the gyration. Again, we are in isolated myelomeningocele. MR confirmed the ultrasound in all cases, and has provided additional findings in only 2 cases, mainly for the heterotopia, with a very good correlation and a good proportion of agreement between what we see on the MR, what we see on the ultrasound, and what will be the final results, which means that before birth, you can have a perfect prognosis on what will be the child, considering the gait, the sphincters, the Chiari, the hydrocephalus, and the mental delay. And again, what is important, and mainly important on the ultrasound, is to determine the higher level of the meningocele, because this will conduct the gait prognosis. Impossible to walk above L2, difficult to walk above above L5, and the transition is between L5 and S1. And this is exactly what was shown in this recent paper. Good correlation between ultrasound and MR, and very good agreement between before birth and after birth, with the median of 1 level of difference, which means that you can have a good discussion with the parents as far as you have a good ultrasound and you have the results of this good ultrasound. Which means that, and again, the impact on the functional part of this myelomeningocele only depend of the level of the myelomeningocele. which means that the only thing we want to know, in fact, before birth is, are we going to deal with an open or with a closed malformation? Or it's open and it's a myelomeningocele, or it's closed and it is all the other things we have seen. And when we look to the prognosis, except for syndromic form or caudal regression, the prognosis is rather good. About 80 to 90% of these children are normal at birth. There is no emergency to treat. The surgical treatment is doable, and 80 to 90% of these children will be normal when they reach adulthood. Which means that it's very simple. You have bad cops and good cops. Bad cops, myelomeningocele, good cops, all the other malformation, and specifically the LDA. Or we can think to that as beginning. So for myelomeningocele we know is a very severe but not lethal malformation. And if you look to the death rate, it's 8% at 5 years in the US and 10% in the huge European survey at 20 years. And most of them died for shunt complication, for shunt dysfunction. You know that spina bifida is coming from Nicolas Tulp, who was a very good friend of Rembrandt. And he spent, this is Nicolas Tulp paint in the anatomical lesson, which is in Amsterdam. And when you think to myelomeningocele, you have two things. You have to deal with a functional handicap, which means the paraplegia and the sphincter incontinence, and with the mental handicap, maybe, but only maybe in relation with the Chiari, the hydrocephalus, and the main disorganization. And in fact, since the first surgery described, we have nothing, or we had nothing to treat this myelomeningocele. The only thing we are able to do is to avoid the suprahandicap by doing a surgery during the first day of life. I say the first days because nothing is proved between the relationship between a very, very early surgery or a surgery done at the second or third days. And this is what we are able to do. And we know that the results are not so good. Of course, the difference between the high and the low. Something happened to my microphone, or you are okay? No, it's okay. So between the low and the high, between the low and the high myelomeningocele, but when you look to what you will have in adulthood, the life of an adult myelomeningocele is not so fancy. Difficult schooling, difficult living, low access to work, low access to familial life. So how can we do to have a different results? In fact, only three things: the primary prevention with folic acid, the antenatal diagnosis and termination of pregnancy, and the antenatal surgery. For the prevention with folic acid, this has been a big turn in the history of myelomeningocele. This is what's called a paradigm, and so a paradigm as important as the beginning of the books or the computers or the fire, or Joseph Lambeau, who has discovered the concrete, or for us doctors, what has done Harvey or Semmelweis, or in geography, what has done Wegner when he described the continent and the formation of the continent, and everybody laughed of him for 40 years. This is exactly what happened to this guy, Richard William Michel, which is a pediatrician who was working in Liverpool and in Leeds, who have sent more than 40 letters to the Lancet saying there is something with the alimentation, there is something with the vitamin, there is something with the vitamin B, something with the vitamin B9, something with the acid folate, and everybody was laughing to him for more than 30 years. And it's very interesting to read all his letters. And of course, after that, as soon as you know, it's always obvious. And this is the main thing because of this study, and just one study, which was done in 91, which was a perfect study, prospective, randomized, double-blind, multicentric, international studies. It has been proved that the folic acid has a very, very, very protective role on myelomeningoce cell. And when we always, all of us are saying to our patients, you know, if you take your folic acid, you will prevent 17% of the myelomeningoce cell. It only is coming from this study. After that, there have been a lot of studies. You know this one in the States. You all know the huge Hungarian study which proved exactly the same thing on thousands of women. And just to say a word on my country, unfortunately, it is mandatory to give acid folic, but nobody is given acid folic to women, and there have been no impact on prevalence and no improvement during the last 20 years. And we are it's terrible, but we are the worst country in Europe in terms of prevalence of acid folic. Less than 23% of women are taken acid folic, and most of them not in the good way, which means before and after the beginning of the pregnancy. So the second step is the antenatal diagnosis, and we have seen that it is easy to do the antenatal diagnosis, and we must discuss of the termination of pregnancy, knowing that it's not equal everywhere in the world. It's still blue in the States, but it decreased, and in many countries, as in Brazil, it's forbidden to have termination of pregnancy. What happened in Europe? If you look to this curve, there was a decreasing with folic acid, the decreasing because of termination of pregnancy, and we dropped, and we dropped down to 16 for 10,000 to 2 for 10,000 during the 20s last year, but it was not exactly the same for all the countries. As you can see, we are the worst country in Europe for the prevention, and the number of myelomeningoce increased in France during the last years. And on the opposite, the numbers of living births decreased because the termination of pregnancy. And if you look to the termination of pregnancy specifically for myelomeningoce, it's 25% in the States, 78% in Europe, and in my country, it's between 85 to 95%, as you can see, 100% of diagnosis, and between 90 to 85% of termination of pregnancy, which means that about 20 years ago, the numbers of living myelomeningoce disappeared. So we stopped to do research. We stopped to operate on myelomeningoce. It was impossible to teach to our residents how to operate a myelomeningoce. And those of you who were in Necker 10 years or 15 years ago know that nobody of us were able to operate on myelomeningoce, so we do not start to do antenatal surgery. And on the opposite, when you consider antenatal surgery, you need to answer to several questions. It must be a severe disease with an antenatal evolution. You must have a failure of postnatal treatment. You must have a rationale for prenatal surgery, and you must have experimental evidence of efficacy. And this fits totally with myelomeningoce. You know that it is said that this is a two-hit worsening. You have the malformation, and the worsening of the malformation in utero because traumatism, because acid of the amniotic liquid, because of contents of the amniotic liquid. And the rationale for the facile surgery is to protect the spinal cord and the root, to protect the functional aspect, and to avoid the CSF leak, to avoid the chiari, the hydrocephalus, and the brain disorganization. And if you look to the chemical point of view, when you look to the amniotic liquid and the aspect of the spinal cord, there is contamination with by the vernix with within the dural canal and sometimes the syringomyelia. And this is a very interesting paper from Poland, which was published this year about the inflammation of the skin by lymphocytes and granulocytes in fetus and after birth, and there is no discussion. There is a tremendous difference of inflammation of the skin between and of the dura mater between when you compare antenatal and postnatal children operate of myelomeningoce. And we all know that there is a rationale for antenatal surgery for many, many, many years. And the goal were to decrease the number of chiari, to avoid hydrocephalus, maybe to have access to an improvement of the gait, but nothing on the sphincter. And the price to pay was the prematurity and the risk for the mother. The beginning of this antenatal surgery was a total catastrophe in the 70s and in the 80s. So most of the teams stopped to do it. Then we have had research, case report, few series until the months, which was the turnout of the management of myelomeningoce. You all know the months, so I will be very short on that. You know that the study was with a comparative group. It was stopped because of the discrepancy between the result of the antenatal compared to the postnatal groups in terms of shunt, what was called the composite group, on the chiari, maybe on the gates, but with what was expected, increasing of the prematurity and some risk for the mother. And for us in France, what happened? You remember this curve, and look to what happened during the years between at the end of the years 2000. We have a huge increase of myelomeningoce because of the modification of our population, of the modification of the ethical and religious aspect of our population. And we had to deal from 1 to 30 myelomeningoce in a period of 5 years. So we go back to the lab, we create a model of myelomeningoce in sheep, because there is no natural model of myelomeningoce in a big animal. So you want to work on myelomeningoce, you have to do your own model. And we have done about 80 animal model, and you need to go to the spinal cord to be sure to have a true myelomeningoce. And as you know, in most of the sheep, you have a twin pregnancy, so you can compare the operate, the non-operate, and to see what happened. And as you see, this is a myelomeningoce, this is the chiari. And after surgery, you have the disappearance of the myelomeningoce and the disappearance of the chiari. So we were allowed to do a preliminary trial on 10 surgery to compare to 40 postnatal one, with, as everybody, the criteria of judgment, chiari, shunt, and anatomical level. We did it with my friend Jean-Marie Joannick, which is an obstetrician, and with Federico Di Rocco for the first cases, and now with Timothée de Saint-Denis. We have decided to do only open surgery, classical open surgery, not a minimally invasive open surgery. You can see perfectly the placode and the myelomeningoce. And to try to do, I say try because it's not a success at each time, but try to do a 3 layers closure, and to avoid as far as possible to do only a 2-level closure. The anesthesiologists are very, very, very important during surgery and after the surgery, as is important the closure to avoid the detachment of the membrane, the premature detachment of the membrane, which is one of the main risks of the surgery. And as all the team, we achieved to have the same thing. The spinal cord go back within the spinal canal, and you can see the disappearance of the chiari in a few days, in most of the cases in less than 1 week, and the same results after birth. And if we look to these 10 first patients, which in our trial, we have had no child mortality, no mother mortality. No one has been intubated or needed ICU with a median week of birth at 34. No chiari, not one chiari, only 2 hydrocephalus at the 4th and the 5th weeks. A motor improvement of what we expect, which means at about 2 level, which means that we have had no deficit above L5, and in 50% of the cases, incomplete or total L5. And of course, complete sphincter problem. You know that everybody who is doing antenatal surgery show is the best case, and this is probably our best case. This was an L5, an L3 myelomeningoce, and you can see the good result. But to be honest, most of the results are closer than the results on the right side than the results on the left side. So what happened after the MOMS? First of all, consolidation of the results. The both team of the MOMS continue to publish their results, and each team which is starting the surgery published is experience with good or no good results. Some have a lot of obstetrical problems, some have, and this is one of the most recent papers with many prematurity, about 60% of shunts and 1 death due to prematurity, CSF infection and sepsis. But anyway, we have many papers in the literature. Others are publishing very specific topic, the anesthesia, the result of sphincter, and looking for the result of sphincter, it's always the same thing. The results are bad or roughly bad. And a lot of papers publishing how to improve the surgery. Do we need to do that? Do we need to do that? Do we need a patch? Do we do not need a patch? Do we need to do a graft? And so on and so on. I will be short on that. Do we need to push layer in, into, over, and so on? And of course, the endoscopic procedure. I will come back on endoscopic procedure just to say that we start in our lab 5 years ago, but we decide for the moment to continue on open surgery. And there is mainly 3 groups. The first group is in Germany with not so good results, and I will short on that, and 2 other groups with good results. One group mostly in Brazil, and one other group mostly in Houston and Belgium, and now in England. And I will go back on the results. And one of the more interesting papers, and what we were waiting for, and it was published 2 months ago, is the long-term results. What happened with the MOMS cohort result? First of all, clearly, there is good evidence on shunts, walk, and MRI findings. When you compare the 2 groups, it remains the same thing. On the other hand, when you look to the neuropsychological results, it's not exactly the same thing. Some of the tests are good, some of the tests are not, and it's very, very, very difficult to have an idea. Nevertheless, when you look to the quality of life and when you look to the impact on the family, it seems that there is a significant advantage for antenatal surgery. But if you look to the conclusion of this paper, it's very strange, because if you look to the conclusion within the paper, it's writing this finding on the most rigorous study group of children with myelomeningoce and the growing body of literature demonstrating the benefit of prenatal surgery. And on the other hand, when you look to the conclusion on the same article on the abstract, it's written that there was no significant difference between surgery group in overall adaptive behavior, which means that it's not finished. We need to have more and more and more results. We know that it's clearly working. This is from the Mayo Clinic few days ago. That's why I put it in my paper, but we have all the same results. It works always with the Chiari. We know the problem with the pregnancy and the risk of uterine rupture and the risk of fetal death for the subsequent pregnancy. And this is a real risk, specifically if we do open surgery. And if we look to the surgery itself, we know that the ratio of obstetric complication, even if in our series it's lower, if you look in the literature, it's about 78%, specifically the chorioamniotic membrane separation and the preterm prematurity. That's why when you look to the neurosurgeon opinion on the prenatal management, it's so-so. A big study has been done all over the world, and you can see here the answer. And the main objection to the antenatal surgery is not the ethical concern, is the risk of fetal complication, it's the risk of maternal complication, is the lack of total evidence for benefit. And on the other hand, the more important reason to provide this antenatal surgery is clearly the decrease of shunt dependency. So where are we considering the risk of hydrocephalus? If you look to the risk of rehospitalization for hydrocephalus or shunt dysfunction, there is no doubt that there is a huge significant difference between the prenatal and the postnatal. All the series, endoscopy, surgery, everyone has the same result, a dramatic decrease of shunts and of shunts complication. And this is completely clear in all the papers. And if you look to the guidelines of the American Society, it's clear that there is a difference. It is recommended to do the antenatal surgery because of the decrease of shunt dependency. But if you look on the last paper before he died of Noël Tulipan, in fact, what he observed is that there is 3 groups of ventricular dilatation pre-birth: normal size, intermediate, and huge ventricular dilatation. And when you look to the benefit on the risk of shunt on the 3 groups, in fact, he think and he discovered that there is not a huge difference, which means that he proposed not to do antenatal surgery if you have a ventricular dilatation above 50. On the other hand, if you look to the other group, the group of ATSIC, in fact, with absolutely the same technique within the same trial, there is also a small difference, which means that over 15, the prevention of hydrocephalus is less efficient. But what he writes in his paper is that patients should be made aware of the variability within atrial dystron group, and this should not be used as the hard cutoff for offering fetal myelomeningoce treatment. So that means that this point cannot be completely proved and completely solved for the moment. Then, how to treat the hydrocephalus? There is more and more a trend to propose, even for myelomeningocele, and even for those who have had antenatal surgery, endoscopy. And in the group of St. Louis, when you look to their experience, on their 60 patients, 27 years of age, operated on at 24 weeks, L4, L5, L3, L4 myelomeningocele, short surgery, 43 minutes. And what happened is that they have about 50% of shunts, and among these shunts, they have done mainly ventriculocysternostomy. You will see that here, 25 ATV, and only 6 ventriculostomy, with a success of 50% for the ATV. And if you look to the significant cause of success, it was the age, the later one. It was the gestational at the moment of the myelomeningocele repair, the early one, the ventricle size, and the ventricle size post repair. I will skip that. You know that it is said that it's difficult to do ventriculostomy in myelomeningocele because of the mass intermedia, and you can find that in many papers. I've just put the papers of my colleague in Lyon, and I say that Federico is here. So hello, Federico, who have a different opinion and experience with good results with endoscopy associated with coagulation of the choroid plexus. So, now I will skip that. So where are we now? There is a clear consensus to continue. There is a clear consensus on decreased risk of hydrocephalus, at least if the ventricular dilatation is moderate or mild. Discussion on how to treat the ventricular dilatation, and no clear evidence of impact on neurocognitive development, even if there is an improvement of mobility and independent functioning. There is still few active centers. There is an improvement of the numbers of the endoscopic centers and improvement of the endoscopic technique, and I will say a word on stem cell. That's why it's always difficult to do counseling for myelomeningoce, especially in countries where pregnancy termination is allowed. Just recently, we were in these papers which are important for me. There is some misconception about fetal surgery. First misconception, without fetal surgery, my child has no chance to walk. Second misconception, fetal surgery is a cure for spina bifida. And third misconception, fetal surgery is a new standard for care, which is not. For the moment, the postnatal repair is still the standard of care. And again, a paper published a few months ago on the learning curve of open and endoscopic closure of myelomeningoce, systematic review and meta-analysis involving 18 centers all around the world with 17 series, 11 open, 1 mini open, 1 fetoscopy with exteriorized uterus single layer closure, 3 fetoscopy with percutaneous single layers, and 1 fetoscopy with percutaneous double layers. And if you look to the competency, in fact, it seems that you need between 31 to 60 cases to reach the top of the learning curve for standard. And if you look to the others, it's probably higher, 57 for mini sterotomy, 56 for fectoscopy double layers, and nobody knows, even if there is 20 cases in one case, in this series and 81 cases in these 3 series, to know when people will reach this learning curve. That means that you need to be very busy if you want to start this kind of treatment. What we know is that all fetoscopy are significantly longer than standard hysterectomy. Nobody knows what is the metabolic effect of the CO2 on the fetus. And again, we need to have more results to determine what to do. And if you compare, at least in this paper, the results of the different technique, it's very difficult to give an idea. If you do how to achieve the untethering of the placode, it seems to be better in standard hysterectomy. If you look to how it is possible to close the placode, it's open and discussed, but to be able to do 3 layers, in fact, it's clearly more easy in standard hysterectomy than in endoscopy. And it's a longer operation. On the other hand, you have less probably, and you have a little bit more technique failure, but you have less rupture of membrane, and the long-term results are discussing, because it's again very, very difficult to know what is the best result, even if you want to have the longer result, and maybe we will discuss of that with pleasure. And this is the last part of my talk. I will be back to our practice. Look to what happened I need 10 more minutes. Look to what happened in our team during the last year. We have seen 133 cases refer for antenatal surgery. That means parents who do not want termination of pregnancy and who want to discuss the antenatal surgery. First result, we have 20 mistakes, and I will insist on that, 20 mistakes on these patients coming from reference centers which have not myelomeningoce. Then 10 non-eligible to prenatal repair, some loss for follow-up, but look to what? At the end, we have to deal with 93 myelomeningoce. In fact, 55 at the end of the day of the recruiting day, 55 patients or couple decide to go for termination of pregnancy. Then 18 ask for postnatal repair and only 16 ask for a prenatal repair. All that for that, which is completely different, I know, than in many countries and specifically in yours. And the end of my talk will be on that, on the mistake. I'm sorry. Will be on the 20% of non-good diagnosis. That means that diagnosis of myelomeningocele, it was proposed to the parents to do a termination of pregnancy. They asked to have information of antenatal counseling, and at the end, when we saw them, we know that this was a bad diagnosis. This was our first example. Obese patient, first pregnancy, not really a huge carry. And if you look to the aspect of the lesion, it's not really a myelomeningocele, because you know that the spinal cord is going outside and go inside. There is a tract, and you can see clearly the tract here. You can see here the spinal cord, the not too wide opening of the spinal process, and of course it's a limited dorsal myeloschisis. So they decided to continue the pregnancy. This is the aspect at birth. The surgery was done at D12. And you can see it. You all know how it's easy to do this surgery, because you have the spinal cord. You just have to detach the tract, to put it back in the canal, to find a way to do the plasty. And of course, this child will be completely perfect. He has now 6 years, and he is totally normal. There is, and these are simple cases of myelomeningocele. Some are big, some are small, some are high, some are low, but all of them are completely normal. So it seems to be clear that there is a clear cut between the open dysraphism and the closed dysraphism. And this is what we published 4 years ago, and we were very happy of us. We find a solution between the good things and the bad things, the good form and the bad form. But in fact, as usual, it was not so easy than that. A few months after that, we have these cases. Is this normal? You can see here that the tract goes almost to the skin. You can see here again the tract here. You can clearly see the tract, the small tract of the spine here. So is it a myelomeningocele? Is it not a myelomeningocele? We discussed For weeks and weeks, the parents decide to continue the pregnancy. And at birth, it was not a myelomeningocele because there was no placode, but it was an open malformation. There is no carry, and the results were in between. The child can walk, but badly. He had constipation, he has no dysuria. So the result is in the middle. Here, another cases, it's clearly an open malformation, but if you look to the spinal cord don't go to the skin, but you have a phylum, so this is an open phylum. If we continue, look here to this malformation, which is again different. You have the spinal cord who do that and backward like that. No hydrocephalus, no Chiari, and this is at birth. It looks like a myelomeningocele, but it's not a myelomeningocele. There is no placode, absolutely no placode, and the spinal cord is attached here on the skin. And if you look to how it looks, it's very, very close of what we've seen on the LDM. You see that. So it was very easy to operate on it. It was exactly the same surgery than on LDM. It was easy to put back the spinal cord within the canal, to put a patch, to achieve the closure of the skin. You look to the aspect of the skin, and this is it. And the child is completely normal without any deficiency, which means that the cut is not so clear. And probably there is a continuity between both. And if I want to come back to what I showed you previously, and there is probably other aspects that we need to deal with. That's why I show you back the difference with between myelomeningocele and myeloschisis. And in fact, if you look in the literature, when you want to find out the cause of worse results in the lower limb between in these children, there is one extra factors, which is the traction on the spinal cord, as I showed you previously. And if you look to the probability of TALIPs looking to the volume of the meningocele, it's a perfect line, and it's very, very, very significant. And in fact, it has been written, it's also the same thing in the Farmer papers recently, and it was written, in fact, so huge difference between SAC and no SAC, and it was written more than 10 years ago, and the difference between the myelomeningocele with SAC and the myeloschisis with better result, and probably there is a traction effect. That's why we published a letter, which is an press on what we call MyLDM, which is the intermediate form between myelomeningocele and LDM. And we need to do a distinction between at least this three form and this intermediate form. And we don't know the exact prognostic of this form, and probably we must take that in account during our counseling, during our proposal of treatment, that the degree of stretching of the spinal cord is a very important factors on the evolution. And what we also want to underline is the existence of such intermediate form, which might explain some surprising good results observed and published, because probably some good results without Chiari, without sphincter problem are not really myelomeningocele, but closer to this MyLDM. Just to continue, this is another form. You see the spinal cord, it goes down, it ends on a lipoma. you have tract within the sac. And when to look to what happened, this is the surgical aspect. You see the cord, you see the end of the cord, you see the lipoma, you have the tract within the meningocele, which is another form of dysraphism, which means that, in fact, if you consider the defect of neural closure, you have a perfect continuum with all these forms and not a separation between the disjunction and the primary neurulation. And in fact, we have the good, the bad, and the ugly. And to end, what we have seen myelomeningocele as here, you see the spine, the wide opening, the wide neck at the level of the spine, the root within the spine, which is a classical myelomeningocele. We have seen the classical limitodorsal The spinal cord go out and back, the stalk, not opening of the skin, no root within the sac. We have seen intermediate form. You see, sorry, yes, you see here the association of low spinal cord, lipoma, meningocele, stalk, and nobody knows how to name that. We have seen this kind of MLDM, which means the spinal cord go outwards, but no placode. Roots are going back within the canal, small opening. We have seen maybe this other type of, we have seen this other type of MLDM with the traction on the spinal cord. And I have no time to show you some myelocystocele which came from exactly the same family, which means that, in fact, we have severe form, and myelomeningocele are the more severe form. We have intermediate form, and we have benign form of dysraphism, and all of them can be confused with the other. And it was probably what happened previously when none of us take interest in myelomeningocele. So, which means that now we need to do sur-mesure evaluation. We need to know if it's isolated, open, where is the level, is there hydrocephalus, what is the size of the sac, and is there some stretching, which are the cerebral anomalies, and all the other things. And in fact, from the myelomeningocele and the LDM, there is probably, there is probably some room for intermediate form that we call MLDM. So just to finish, where are we? There is a clear consensus to continue what we have seen. And as I told you, 2 words on the end of our practice. We have decided to continue open surgery, but to go for fetoscopy specifically for sacral myelomeningocele and MLDM, specifically when you have a stretch, and we will start fetoscopy, but specifically for these cases. And we have started our research 3 years ago on cell therapy for prenatal repair of myelomeningocele. Lucie Guilbeault, which is leader in this group, had just ended its PhD on that. The 2 main teams are on both parts of the United States. And what we must keep in mind is that this has only a paracrine effect, which means that the role of the stem cells therapy is to protect the spinal cord, to give nutriment, to help it to heal, but there is no regrowing of the spinal cord at all. What kind of stem cell is used? And this is a trial, and we have done several ships now. So we create the model you have seen previously. We repair it as you have seen. We put a patch of stem cell, of mesenchymal stem cell, and we observe how are the shifts afterwards. So I've reached the end of my talk, and I come back to the beginning just to have a great thing to Jim Grudish. I think to him during all my speech and all my memories in your country with him, and you see that it would start many, many years ago. And I will end by a sentence that all of you knows. This picture was done in Paris, in one of the best restaurants in Paris, at the end of a meal, when we test Armagnac from 1902 to 2010. And you know that he end all these lectures by this sentence, and in nomine Patris and Filii and Spiritus Sanctus. So I thank you. Thank you very much.
Thank you, Michel. Thank you so much for your very complex presentation. And I think that you have some questions for you. It's a very nice, huge revision of the literature about this important topic, because I think that more and more countries around the world are doing antenatal surgery for myelomeningoce. So it's very important to talk some things clear. And I love it when you showed about maybe the misdiagnosis related to some case that people sometimes showing very good results, but in fact could be not myelomeningoce as you show. So I would like to invite to Ricardo Gap, that is our moderator of this talk, and we open the micro for everyone that we need to make some questions. So please, Ricardo.
Thank you, Ricardo, and thank you, Professor Zerah. It's a great pleasure. And congratulations for your wonderful speech. So I have a couple of questions from...
Sorry.
Two lesions. What do you prefer
Ricardo,
to do?
Ricardo, I don't listen to the beginning of a question because
okay.
Yeah.
If you have two in the same patient, two lesions, what do you prefer to do at first? The most rostral, the most caudal, and you see any special difficult because there's two lesions at the same patient, too close, the fascia and the skin? And
what you mean by two lesions?
The same. You show it two lesions at the same patient, and in one more rostral than other caudal. It's not a very common case. So someone in the audience asked about what do you prefer to do first?
My only experience was diastematomyelia and the myelomeningocele. I've never had two myelomeningocele, but if I had a myelomeningocele, I think I will try to do both, because I'm doing open surgery and I think it's completely doable to do both. For the diastematomyelia, in fact, we close the hemimyelomeningocele on one side. We do not touch to the diastematomyelia, and we do the surgery for diastematomyelia after birth. But if you have a double myelomeningocele, I think I will propose to do both lesions.
Okay. I have one personal question, Professor Zerah. The same group that published about the meta-analysis about American meta-analysis about the fetal surgery published that the incidence of tetrachord cord is huge in the patients that did the prenatal surgery. What do you think about these results?
Again, first of all, I do not know, because I do not, in my experience, I have very, very few cases of test cord after postnatal surgery, which is one point. And we have had known after antenatal surgery, but have you seen our series is small. So I am unable to know what is the answer. If you look on the papers, it seems that you have less test rod cord in fetal than in open surgery, but really I don't know. We need to wait and to have the results. And maybe one of the advantage to use the stem cells at the end of the surgery, that means that you do the surgery, you put your patch of stem cells on the spinal cord or on the dura, then you try to do your 3 layers. Maybe it will lead to decrease the numbers of test rod cord, but I have not the answer. First of all, because I have not the experience of both, and because my series is small, and I think we need to have evidence in the literature to know that. And I'm concerned not in people who do fetoscopy with 2 layers closure or 2 or 3 layers, but just to put a patch, and 1 layer for me, definitively it's a bad solution. But again, between endoscopy and open surgery, I prefer to do for the moment open surgery, but I completely accept, and I'm looking for what happened with the endoscopy, and I've been to see my colleague which are doing the fetoscopy. I must here thank all the people in the world who welcome us, our team, to see their practice, because we learn a lot just doing everywhere.
We have another question from the audience about infections rate in fetal surgery in your practice. Do you have any case, and
no,
what do
no. We have known there is in most, to be honest, in most of the cases, the ratio of infection is low. We take precaution, we give antibiotics, but the ratio of infection in our group is known, and in the literature, it's very low. There is one on one of the papers I've shown to you, but in most of the paper, it's low.
Michel, we have another question from Nilsi.
Yeah. Yes.
She asked you if you have a fetus with a ventricle over than 15 millimeters, did you still indicate fetal surgery for myelomeningoce?
For the moment, yes. For the moment, yes. You know, you have seen the discussion between the group of Tulipan and the group of ATSIC. For the moment, yes, but maybe in 2 years, in 3 years, in 5 years, it will be different. But I think we need to have more results before saying we need to stop to do fetal surgery when you have a huge ventricular dilatation.
Yeah. I'd like to invite you, Girish, to talk with us. Girish, please.
We have European people.
Hi, Michel. Congratulations. Lovely presentation. Really enjoyed it. 3 points. One is timing of prenatal surgery. The surgery is done after 23 or 25 weeks. It appears that this may be associated with slightly poorer outcomes. And this is one of the concerns that have been raised about fetoscopic surgery being done after 25 weeks. And therefore, the sooner the surgery is done, the better the outcomes. And I was very interested to hear about the myelic LDM proposed. I think that makes a lot of sense. And we wondered whether the myelomeningoce is not a static lesion that happens on the first day and stays the same, but a progression. The longer the pregnancy progresses, or the earlier the sac ruptures, and as more CSF leaks out, more of the nerves and the plaque then stick to the skin. So if you were to operate earlier, would you see a less myelomeningoce, as you're seeing, actually, an intermediate condition. So that, I think, is something that I was wondering whether you had been able to assess the age of the gestational age of the surgery in relation to finding lesser lesions, because that might first make that decision. And of course, these are the 3 points, really. Thank you.
Okay, first of all, what is classical is to operate before the 26th. And we have always done that in our series, which sometimes is difficult because at an ethical point of view, we leave 1 week to the couple to decide if they go for surgery or not, which means diagnosis is done at the 24th, so you wait for 1 week, you need to prepare. But for the moment, we've never done a surgery after the 26 weeks. There is no evidence between the 21 and the 26 weeks. We have done, the youngest was 21 and the oldest was 26 in our series. It's more difficult to do it at 21, but it's doable. But if you look on the results, it's difficult to have an idea. My concern is an endoscopy because not in all the series and not in all the cases, the endoscopy is done later on, and probably the damage to the spinal cord will be worse if you do the surgery later on. And at the beginning, the endoscopy was done later on than the open surgery because the delivery was earlier. But with the progress of the endoscopy, I think that if we want to do endoscopy, we must do it earlier. And for your third question, it's clearly a dynamic problem. It's clearly that when you have a huge sac, when you have a traction, and really we want to say that with Federico and with Timothée, it's very important to consider. That means that you can have a deterioration in utero, even for closed lesion, and we need to think really about that.
Thank you.
Professor Zerah, we have a couple of questions from the audience. The first is, do you think there is any space to ventricular-amniotic shunt in patients with huge hydrocephalus?
There is surely a place for that. We have never discussed that. I have no experience of shunts. I have experience in ventriculostomy, but not for myelomeningocele, for third ventriculostomy, but not for myelomeningocele. Probably, if we do a surgery very early and you have a huge ventricular dilatation, which is progressing, maybe that will lead to a discussion. I don't know if Nelsie or other people who have also experienced in the, or Eduardo, who have also experienced in the audience, have an answer to this question. But why not? Why not? But it starts to be a little bit difficult.
Michel Sainz asked to you, how many days you keep the mother hospitalization with after antenatal surgery? This
is a very good question. What is important to understand is that the main risk is the prematurity, the precocious delivery, which means that we keep the mother between 7 to 10 days after the surgery in our clinic, just to be sure that everything is okay. And after that, we ask her and we ask the father that the mother must go back at home and do nothing. The cooking, the care of the children, and the laundry, everything must be done by the father, and the mother must remain as quiet as possible just to avoid the prematurity. And this is very, very, very important.
Michel,
yes.
Sergio is here with us, and he has one question. And have you seen brain malformation in this new phase myelomeningoce that you showed?
In LDM, not for the moment. Neither in LDM, neither in LDM. But again, this is the beginning of a story, and so we need to learn. It's an ongoing process.
Okay. So, Michel, I have a personal question for you about in the beginning of your program in Paris. What, in your opinion, what were the main challenges to start the program?
So, first of all, I think that you need to work in a lab. That means that we have operated on 80 ships before doing our first cases. Secondly, we travel a lot, and in fact, I want to thank Sergio, because we went to São Paulo with my friend. He opened everything, and we see exactly how he was doing, and we take a lot of information of that. And after that, what we do is that we rehearse a lot with Federico and Jean-Marie Joannick. That means that we do fake surgery, mock surgery, how to put everything in the room, and Federico has a drawing with everything in the OR. We choose the nurses, we choose the anesthesiologist, everything. We be very, very careful with the material, which means that, and I think that's why our learning curve is under the learning curve published. That means that, in fact, we were very happy for the first cases, but it were uneventful. That means that you really need to be prepared, but if you are prepared, it will be, I think it will be okay. But I think you need to rehearse in the lab just to know how it is. Go and see your friends, and if you can, go and see endoscopy and open surgery, and do at least 1 or 2 fake surgery just to be sure that everything is okay.
Professor Zerah, I think a very important point that you showed us is the prenatal appointment by the neurosurgeon. Sometimes yes, we think that the obstetricians have most power to decide some of the procedures, and of course they prefer to do the surgeries, the prenatal surgery. So this prenatal appointment with the neurosurgeon, it's very important, I think. So of course the media has a very important power for the families, and the families come to the hospital sometimes very anxious about to do the prenatal because they think that's the better option. Do you think that some families could change their opinion after a good prenatal appointment with the neurosurgeon?
This depends on your organization. What we have ourselves is that we have a common clinic. That means that we see the family together. We discuss with them. They spend 1 day with us. We redo the ultrasound, we do the MR. There is a psychological examination, then a clinic with the neurosurgeon and the obstetrician, and each of us stay on each border of knowledge, which means that we speak on neurosurgery, on what is a myelomeningocele, on what is the life of a myelomeningocele, on what is postnatal life, postnatal surgery, and the obstetrician, my colleague obstetrician, explained what is the obstetric risk of this surgery, what it means, what is the risk for the future pregnancy, what is the risk of prematurity, what is the risk of uterine rupture, and as you have seen, there is also a multidisciplinary clinic where all the cases are discussed. And I think that one of the risks of the endoscopy, and what happened in some place in the world, is that the endoscopy is not done by a neurosurgeon, by a general surgeon. And this is also a challenge for us, is to be able to do the endoscopic surgery, because if you look to the skills of a general surgeon and the skill of a neurosurgeon with endoscopy, we need to work a lot to be skilled. And this is for me one of the risks. And on the opposite, our advantage is that we will take care of this child for 20 years or more, and we know exactly what is the reattachment, what is a dermoid cyst, what is a scoliosis, what is a clubfoot, what is the urinary problem, and nobody can replace our knowledge on that. That means that we need to be equal between the obstetrician and us. And the team which are working well are the team where you have exactly this balance between the obstetricians and the neurosurgeons.
I think there are some questions about the layers that you use to close and about the duro and the skin substitutes. So do you think, and what kind of are you using?
We don't use substitute. We try to use, we have just done once some discharge laterally, but we try to close with the skin itself. And it has been doable for the moment in all the cases. Sometimes you need to dissect under the skin to have enough plasticity, but it's doable. What we do is to use or fiber glue or tacosil that we put just on the spinal cord to secure it during the surgery. Of course, we do the closure of we do the neurulation. After that, we try to find out dura and muscle, but this is not doable in all the cases. Sometimes you can do 3 layers, sometimes you can do only 2 layers, but up to now, we have never used any substitute, any artificial substitute. But our dream is to have the stem cells in some years from now.
Professor Francisco Solomon has one question for you about how long time do you follow the patients with ventriculomegaly until you decide to realize they don't have hydrocephalus?
In fact, our routine is to follow these children for life. So we continue, but in the protocol, we saw the children at 1 month, 3 months, 6 months, 1 year, and after that, every 6 months. And in fact, we have had no acute hydrocephalus, and the 2 children who have had shunt is very slow growing hydrocephalus. So we discussed to do, not to do, to do, not to do. And at the end, we did it. But as you've seen, we have about 20% of hydrocephalus up to now. But the follow-up is forever. And if you look to the biggest series of the meta-analysis, what is clear is that if you compare the moment of the shunt in the postnatal and the antenatal, in the postnatal and the antenatal group, there is a huge difference. The shunt, when it is done in the antenatal group, is later on bigger children with less complication, less infection, and less redo.
Okay. Gish, do you have some question? Please, Gish.
Yes.
Sorry.
I can wait for after Professor Solomon's question.
No, it's okay. It's on.
It's done. Okay.
Yes.
So, Michel, in the same vein, and I think it's very much in line with what Professor Cavalier was asking as well. If you end up operating on these children earlier, it is possible that less of the brain will migrate downwards, particularly in those where the sac is leaking. And does that mean that it is possible that you may have less aqueductal stenosis, less abnormalities of the corpus callosum, less migration abnormalities? Of course, theoretical question, but you may have some information or idea already from the cases you're operating.
No, I have no idea, but if you look to what happened and to what happened in all the series, is that when you do antenatal surgery, the chiari disappear very quickly and the aqueduct reopen itself, which means that there is a plasticity that allow you to hope that if you do it at the 23rd, 24th, or 25th weeks, it's enough. It's probably not enough, but it's enough. And you know what I fear is to damage the tip of the conus with the surgery and to increase the sphincter problem if I do it very, very, very early. But we will see. I do not know. And the cause of the hydrocephalus, there is one paper I didn't show, is probably not the chiari, because if you look to the antenatal or even the postnatal with disappearance of the chiari, the ratio of hydrocephalus doesn't depend on the existence of a chiari or not. Probably there is other cause of hydrocephalus than the chiari and the aqueduct stenosis.
Thank you.
We have one last question from Nelsi for you, Professor Zerah, about the stem cell patch. What can you talk a little bit more about how do you use and kind of this stem cell patch?
I use what?
The stem cell patch.
Yes. First of all, we use them only in our lab on chips, huh? Okay. And we have a long way to use it on human, because this is a preliminary experience. But for example, Farmer in Sacramento is in advance with us, and he has good results on sheep also. The idea is that and again, it's difficult to know if you need to use stem cells from the embryo, from the amniotic fluid, or mesenchymal cells, but most of the team for the moment use stem cells, mesenchymal, from the umbilical duct. And what it seems is that when, and you put that on a gel form, and you put it on the spine, just like that. And what seems to happen is that they give nutriment and probably healing factors to the spinal cord, which help which help the healing and decrease the apoptosis. What it has been shown that the ratio of apoptosis at the level of the placode decreased consequently, decreased significantly when you use the stem cells. But it's not treat surgery or stem cells for the moment. It's just surgery with the help of the stem cells at the end of the surgery.
Thank you. Ricardo?
Yeah, Michel, the last question from Marcius, it's about, in your opinion, about the bed rest position and surgical dressing for the neonate after myelomeningoce repair. What is your opinion about the bed rest and dressing?
I don't care. Really, I don't care. In my department, some are really fun to put it on supine prone position, but in fact, I don't care. What as the nurses, in fact, is to move in, to turn in, but I don't care.
Okay. So, Michel, I think that thank you for taking your time to be here with us, sharing this excellent lecture. It was a great pleasure. And also, I'd like to thank you all the participants to stay with us. And the last speech for you, and great for Suresh from India, Girish from UK, and we have a lot of people from different parts of the world. It's a great pleasure for our society.
Thank you, Ricardo. And my only hope is to be able to come back to Brazil and to spend times and drinks and sun with you as soon as possible. So all of you stay safe, and I hope this will finish one day and we will be able to meet again.
Okay. Thank you.
Thank you. Thank you. Thank you again to take time to listen to me.
Okay. Thank you, everybody.
Bye-bye.